Good morning, everyone. We will do the technology table today, as we have already discussed the technology based on BPH and stones. We will do something like a miscellaneous technology. We will try to cover as much as relevant technological details possible today, and rest of the technology we will cover in the upcoming 10-minute sessions. So shall we start now?
Yes, please.
Thank you. So you are on the technology table. The discussion is regarding the need for a pyeloplasty for a patient with a hydronephrosis. So what is Renogram?
Renogram are imaging study mainly using the radioactive isotopes, and usually in the Renogram we have two elements, the radionuclide label and the pharmaceutical. Usually they are combined together, given to the body, and then we are looking for activity in the form of gamma rays, which is detected by a special gamma camera.
Well done. One of the keywords I would suggest to bring in is the time activity curve, and it is the depiction of the time activity curve which is called as a Renogram. The description was right. What are the types of Renograms available?
So the types of Renogram include the DMSA, dimercaptosuccinic acid, and the MAG3, mercapto-acetyl triglycerine scan, and also we have the DTPA, which is less commonly used.
Okay. What is the most commonly used Renogram in our day-to-day practice?
Actually, it's most commonly used are the MAG3 and the DEMSA. It depends on the indication. If we are looking mainly for functional outcome, looking for obstruction, then it is MAG3. If we are looking for cortical thickness and residual renal function, then it is DEMSA.
Okay. So for this lady with a hydronephrosis suspecting a PH obstruction, which is the ideal Renogram?
For this lady, since there is a suspicion of obstruction, then we will do MAG3.
Okay. What is the mechanism by which MAG3 is cleared from the body?
90% will be cleared by tubular excretion and only 10% via glomerular filtration.
Well done. Are you aware of the O'Reilly curves in diuretic Renogram?
Yes. O'Reilly curve, there are four types. Type 1 is the normal curve in which there is a rapid increase in the curve or rapid rise in the curve initially due to the vascular phase, which usually occur within 20 to 30 seconds, and then after that there will be a slower increase in the curve, and this is due to the parenchymal uptake or the renal uptake of the radioactive isotopes, which occur usually from 2 to 4 minutes, and then after 5 minutes the curve start to go down due to excretion of the radioisotopes. So this is the normal curve, which is type 1. In type 2, there is uptake of the radioisotopes, but it remains high. There is no excretion due to obstruction. Type 3, we have two form, 3A, in which there is a hypotonic pelvis, so there will be a hold-up of the radioisotope to start with, and then after injection of the furosemide, there is a good response and excretion of the radioisotopes. And we have the type 3B, which is the equivocal one, where there is an initial uprise of the curve, of the radioisotope curve, and then it remains high for a while, and then it start to go down slowly. So it is not persistently high or plateau as in the case of obstruction, and it is not excreting the radioisotopes normally like the normal cases, so it remains in between them, which we call it the equivocal case. And then the last type is the delay decompensation, where there is an initial rise in the curve, and then after that, after giving the furosemide, there will be some response, and then the curve will start going up again, which is called delayed decompensation.
Okay. Is there any particular name for that delayed decompensation?
Yeah, it's called homocysteine.
What is the reason for homocysteine?
The possible reason is either partial obstruction or reflux, vasogastric reflux.
Okay. And homocysteine can also happen in high flow obstruction.
Yeah.
Okay. So the system will not be obstructed in low flow, but if there is obstruction in high flow, it can cause a delayed rise in the contrast.
Yeah.
Sorry, not contrast, the renogram curve.
Yeah.
And what?
Can I just ask one thing? My understanding is that the O'Reilly curve are relying on furosemide at plus 20. Is that right or not?
That's right. So that is one of the questions. So O'Reilly curves is based on F plus 20 renograms.
Yeah, thank you.
So what are the other time sensitive renograms?
The most commonly practiced now is minus 15, where the furosemide is given at a dose of 0.5 milligram per kg 15 minutes before starting the renogram. And the main advantage is that it reduces the rate of equivocal curves from 15 to 7%.
Okay. And what is F0 renogram?
Is to give the furosemide at the same time of the radioisotopes.
Well done. Although it is very less commonly used now, what is DTPA?
It is, I can't remember the name.
It's not commonly used. So it is diethylene triamine pentaacetic acid. What's the reason that it is not favored compared to MAC3 or DMSA?
I think because the accuracy of MAG3 is better than DTPA, therefore it is not used anymore.
Exactly.
Since the MAG3 now become more popular.
Exactly. And one of the advantage of DTPA is it is relatively inexpensive compared to the other two, but because it is excreted through the kidney and because it is dependent on GFR, it is less useful in patients with renal failure.
Yeah.
But the other two, the MAC3 or DMSA, can be used in those cases.
Yes.
I think that's a good discussion. Shall we move on to the next topic?
Yes.
Okay. You are planning for a cystectomy for a patient with a borderline cardiovascular reserve. You send the patient for a high-risk anesthetic assessment, and the anesthetist suggested to do a CPEX study. What is CPEX study?
Yeah, CPEX or CPET recently called, it is a cardiopulmonary exercise test, which is an objective assessment of the status of the respiratory, cardiovascular, and metabolic response and stress, which is similar to the situation happening in surgery. So basically it's composed of 4 phases. Usually it's associated with very low risk of morbidity and mortality, about 1 to 2 per 1,000. Therefore it needs to be done in an environment where all the resuscitation equipment and team are available. And the phases of CPEX include rest phase for 3 minutes, and then unloaded cycling for 3 minutes, and then ramp phase for 8 to 12 minutes, and then recovery phase for 5 minutes. And we are looking mainly for parameters in the inspired air, like the VO2, and also looking for the excretion of CO2. It also includes monitoring of the blood pressure, 12-lead ECG. All this will be done in supervised environment.
Okay, well done. So what are the you said about the measurements, but what are the hardwares that are needed for a CPEX testing?
So you there?
What are the hardware like the components needed for CPEX testing? Not the measurement, but the setting up.
Okay, I think we need some measurement of the inspired and expired gases. So we need a blood gas analysis, I think, and also analysis of the inspired and expired respiration.
Okay.
We will need cycle. We will need a cardiac monitoring with 12-lead ECG throughout the procedure, measurement, monitoring of the blood pressure and pulse as well.
Well done. And regarding the abdominal surgery, what is the parameter that we are looking at to decide whether the patient is fit enough to undergo the procedure or not?
We have many parameters, but mainly they assess the patient into special risk category, depend on the anaerobic threshold, 80. So if the patient is having 80 more than 11 ml per kg, there is low risk or no risk, low risk, sorry. If it is 10 to 11 ml per kg, intermediate risk. If it is 8 to 10 ml per kg, high risk. And if it is less than 8 ml per kg, it is a very high risk.
Okay, so what is anaerobic threshold? What do you mean by anaerobic threshold?
It means that how the body react to the stress which is induced by intense exercise. In this case, it is the cycling, which we expect that the patient will be under a similar stress during the surgery.
Okay.
So the main aim of the test is for proper perioperative assessment of the patient and counseling about the perioperative morbidity and mortality. It is also useful to look for any new onset pathologies or the effect of a chronic disease on the patient tolerance. It helps also to triage the patient whether they need to stay in a ward or go to HDU after the procedure, and also it helps to plan any perioperative intervention and to plan the postoperative rehabilitation for the patient as well.
Okay, well done. Coming to a different scenario where you are in the theater, you use fluoroscopy in your daily practice, isn't it?
Yeah.
What is the mechanism by which fluoroscopy acts?
The fluoroscopy, it is an X-ray, and the X-ray will act, depend on the electrical current will be changed inside the X-ray accelerator into rapid moving electrons, and then when these rapid moving electrons stop suddenly by a metallic object, this will lead to release of energy, and this will be 1% of the energy changed to X-ray, and 99% will be changed into heat. So inside the X-ray tube, there are two. There are the cathode and the anode. The cathode is the negative, and the anode is the positive. Both of them inside a vacuum. So the cathode is a thin tungsten filament, which is when heated, it will start emitting electrons by the process of thermoionic emission, and then this rapidly moving electron will be stopped by the smooth metallic part, which is the anode, and this will lead to the production of the X-ray.
Okay, so basically it is photons, isn't it? X-rays?
Yeah, so these are the photons, yeah.
Okay. So during fluoroscopy, for example, in while you are doing ureteroscopy, how can you decrease the amount of exposure of radiation?
First, by keeping the X-ray beam very close to the patient as much as possible. and try to, because the main risk during the fluoroscopy is the scattered radiation. So we try to reduce that by bringing the beam as close as to the possible, and try to keep the team away from the patient, because we have an inverse relationship. So as more distance from the source of the X-ray, then the radiation will be half.
Okay, well done. And
Also the use of protective equipment like the lead apron, which reduce the absorbed X-ray radiation of up to 75 to 95%, and it need to be at least 0.25 millimeter thick. The use of lead Google, the use of thyroid protector. We need to minimize the number of the staff inside the theater, and to put a clear sign that X-ray is going on the door of the theater.
Okay, well done. I would suggest to add two more keywords. So one is the frequent use of last image hold function.
Yeah.
And also collimation.
Okay. So what do you mean by collimation?
So collimation is the process by which they can decrease the aperture of the X-ray exposure. So instead of the if you see in the screen, instead of a full screen, they can use so when they activate the collimator, the field of radiation is very narrowed. So that's the only thing that's needed for a minimum. So once you determine your area of interest, then we can request for the radiographer to collimate that field.
Yeah.
What type of contrast do you use in your practice for stones?
I mainly use the Omnipic, which is a low molecular and non-ionic monomer.
Okay. Do you know the generic name for Omnipic?
No.
It is iohexol. So as you said, it is a low molecular non-ionic monomer. What is the advantage of using low molecular non-ionic monomer?
It's associated with less incidence of contrast-related complication, mainly like the allergies, contrast reaction, and the contrast-induced renal injury.
Okay. How do you treat a contrast-induced anaphylactic reaction?
So this is an emergency state. I will call for help. Make sure that the patient lie flat, elevate his legs, and then I will do I will assist the patient according to the ABCDE protocol. Regarding the medication, I will make sure that the patient has a patent airway, start him on high flow oxygen, insert two cannula and one cannula on each side, start IV fluid, and then I will give the patient adrenaline intramuscular, the concentration 1 in 10,000. I will give 0.5 ml, which is 500 microgram intramuscularly every 5 minutes. Until the patient respond, and also I will give after that chlorpheniramine 10 milligram IM and hydrocortisone 200 milligram.
Well done. And also just mentioned about the IV fluid challenge as well.
Yeah.
So well done. It's always the ABCDE, then calling for help, establishing the airway, oxygen, and all the other things that you said, and then the continuous monitoring of the patient. So if a patient is on metformin, this is a different scenario. You are going to request a CT urogram for a patient, and the patient is diabetic on metformin. Are there any restrictions on using contrast for patients on metformin?
Yes, I need to check the kidney function of the patient by checking his eGFR prior to the contrast. So if the patient having a normal kidney function with eGFR more than, I would say, 45 mil per minute, then there is no need to stop the metformin. But if the patient is having eGFR less than 30 to 45 mil per minute, I will stop the metformin 24 hours before and restart it 48 hours after the contrast injection to avoid lactic acidosis.
Okay, well done. What is the fatality rate of biguanide lactic acidosis?
Usually, I'm not sure, but I think it is in the region of 30 to 40%.
Yeah, well done. So almost nearing to 50%. And yeah, the protocols are. The recommendation can vary according to the trust policy, but usually it is the recommendation is if there is renal insufficiency to stop and or withhold metformin 48 hours before, and one of the recommendation is to check the renal function after 48 hours, and if the renal function is coming to baseline, then we can restart the metformin after 48 hours.
Yes.
Okay. What are the most common patient-related risk factors for developing contrast-induced nephropathy?
It is more common in patients with renal impairment, in patients who are diabetic, and in patients with congestive heart failure.
Okay. I would add a couple of more things on that one. As you said, the CKD with a creatinine clearance less than 60, diabetes, as you said, dehydration is one of the common thing that might happen. Patients on diuresis are at high risk, and as you said, patients on congestive heart failure. If there is a patient with CHF with a ejection fraction less than 40%, that patient is also at risk of developing contrast-induced nephropathy. Okay. So moving on, how do you classify chronic kidney disease?
So chronic kidney disease or CKD can be classified according to the value of the GFR, and recently they include also the albumin creatinine ratio in the assessment. So according to the eGFR, we have 5 classes or categories. So CKD1 with eGFR more than 90 mil per minute, but the patient is having moderate or significant albumin creatinine ratio. So albumin creatinine ratio can be divided into less than 3 milligram per mil, 3 to 30, and then above 30, which is a high risk. So any patient with intermediate or high level of albumin creatinine ratio, then this is CKD1 with eGFR more than 90. CKD2 is eGFR 60 to 90. CKD3 is 30 to 60, which is subdivided into CKD3A, 45 to 60, and CKD3B, which is 30 to 45. CKD4 15 to 30, and CKD5 less than 15 ml per minute.
Well done. We'll spend some time on CKD and hemodialysis, because this is definitely a scenario that you can get in the technology table. A couple of my friends during the last exam sessions got the CKD and the dialysis. So we'll spend some time on that one. How do you define chronic kidney disease?
You mean a clinical definition or biochemical definition?
Biochemical definition.
So, as I explained, usually it is a reduction in the eGFR, which can categorize according to the level of the eGFR, and they include also the albumin creatinine ratio in the definition.
So that is the that is the classification, isn't it? Is there any definition for that?
I I don't know exactly.
So CKD is defined as GFR less than 60 on at least 2 occasions, separated by 90 days.
Okay. Yeah. I am aware that the reduction, the eGFR need to stay for 6 months to say that this is a chronic kidney disease.
Exactly. Some definitions say that it should be more than 3 months, but 3 to 6 months is we can accept as definition of CKD. How do you assess GFR?
So GFR is the glomerular filtration rate, which is defined as the filtration of a certain substance through the nephrons. It can be measured either by biochemical way, and also it can be measured using the radioisotopes.
Well done. What are the formulas that you are aware of to assess the GFR?
Yeah. So the ideal GFR we should use an endogenous substance which is completely filtered through the glomerulus without any reabsorption, excretion, or metabolism. And this substance usually is the best example is inulin, but inulin is expensive and difficult to process to use it. Therefore, we are using mainly the creatinine, although the creatinine is not an ideal substance because there is about 10% excretion of creatinine. So most of the formula they rely on the creatinine, and I am aware of 3 formulas to calculate the GFR, and including the Cockcroft Gold formula, which is mainly was measuring the kidney function in normal individual, and there is the MDRD formula, which measured the GFR mainly in patient with renal impairment, and the third one is the
is it the CKD?
The EP, but I don't know the first. What is the first?
Yeah, the CKD EPI, isn't it?
Yeah, it is the CKD epidemiology or CKD epi formula, which I think the best one, since it takes into consideration the female sex and Afro-Caribbean origin. So it adds some correction factor for those patients.
Well done. What is the formula used in your hospital?
It is the CKD EP.
Okay. And you said about assessing the GFR using the what is the accurate method to assess GFR?
The best method to assess the eGFR, most accurate, is by using the radioisotopes. So we are using the chromium 51 labeled EDTA.
Okay.
In this method, blood is taken from one arm, and then the blood sample is kept in a special, well-designed container, surrounded by a gamma camera. The gamma camera will contain the process will start by injection of the radioisotopes, which is chromium 51 EDTA, in one arm, and then after that we start taking blood samples from the other arm at 2 hours, 3, 4, and 5 hours interval, and then the sample is kept in a special container surrounded by a gamma camera. The gamma camera contains a scintillation crystal inside it, and then when there is a decay of the radionuclide label chromium 51, this will cause a release of gamma ray. Gamma ray will hit the scintillation crystal inside the gamma counter, and this will produce flashes of light. This light will be detected by a photo multiplier tubes, which are arranged in an array around the scintillation crystal, and this photo multiplication tube will change this flash of light into electrical signal, and then we can have a very accurate measurement of the GFR.
Okay, so there is a keyword that we had to use in that one. So what happens is, once you take the sample and once you measure the radioactivity of the blood sample, you will plot it in a graph.
Yeah, and then there is a slope, is what they call it.
Exactly. So it is called a slope intercept method.
Yeah, slope intercept.
And that slope of the graph will give us the GFR. So the keyword there is that after the blood samples, it is plotted onto a graph, and that is the slope intercept method.
Yeah.
What are the renal replacement therapies you are aware of?
So renal replacement therapy can be used in patients with acute or chronic renal impairment, and this will include hemodialysis, hemofiltration, and peritoneal dialysis.
Okay. And transplant as well, isn't it? So that's also part of renal replacement therapy.
Yes, this is for the end stage renal disease.
Yeah. Exactly. And what is the difference between hemodialysis and hemofiltration?
So in hemodialysis, it is a diffusive process where we are using a semi-permeable membrane in between two solution with a counter current flow. So the diffusion of the water and solute depend on the concentration gradient. From the higher concentration to the lower concentration, and usually the dialysated fluid is the lowest concentration, so there will be movement of fluid and solute from the blood into the dialysated fluid through a semi-permeable membrane. While in the continuous venovenous hemofiltration, it is depend on the pressure gradient rather than the concentration gradient, so there will be convection of the solute between the two fluid, which are the blood and the filtrate in case of the hemofiltration.
Okay, well done. And what is the advantage of hemofiltration compared to hemodialysis?
So the hemofiltration is a little bit slower and more controlled process, take a longer time, but it is associated with a better cardiovascular tolerability. So it is not associated with a volume loss, hypotension, and electrolyte disturbance. Therefore, it is quite suitable for annual patient in ITU or hemodynamically unstable patient.
Okay, well done. And so what are the indications of acute dialysis?
So the acute dialysis mainly in patient with volume overload, not respond to medical therapy, hyperkalemia more than 6.5, or even sometime lower hyperkalemia but associated with significant ECG changes. Patient with significant uremic symptoms, which usually happen when the level of urea more than 30 millimole per liter. The presence of certain toxin or drug overdose, and severe metabolic acidosis where the pH is less than 7.1.
Okay. How do you access the veins for a patient with hemodialysis, on chronic hemodialysis? What is the best method?
The best method is the creation of AV fistula, which usually we do a radiocephalic or brachiocephalic AV fistula formation, and then we need to wait about 6 to 8 weeks for the fistula to be mature, and then we can use this fistula for cannulation each time.
Okay, well done. And what are the complications of AV fistula?
So the complication is infection at the site, bleeding, which may happen, thrombosis of the fistula, which we can detect it by lack of the thrill, and also the Steele syndrome, which is a distal low perfusion of the organ distal to the fistula.
Okay, what is it called?
The Steele syndrome.
Steele syndrome, well done. And what is the catheter used in peritoneal dialysis?
So peritoneal dialysis, mainly we use a special catheter called a Tinkoff catheter, which can be inserted either by open or laparoscopic surgery. It usually exit through the left side of the abdomen and will be tunneled under the skin to enter the peritoneum below the umbilicus.
Okay. What are the complications of peritoneal dialysis?
So the main complication is infection, blockage of the tubes or catheters, peritonitis, and on the long term there may be lack of efficacy due to fibrosis within the peritoneal cavity, because in peritoneal dialysis we are using the peritoneum as a membrane between the blood and the dialysate fluid.
Okay. Because I was asking about this one because one of my friends got the question of peritoneal dialysis and regarding the method of insertion as well. And he was also asked about the types of Tanchkoff's catheters. So I reviewed it later, and there are two types, swan neck and straight. But possibly
The Tinkoff catheter.
Yeah, two types are mainly used.
Yeah.
Most commonly used are the swan neck configuration, so that there won't be any bend during the exit. But these things can be asked, even though very surprising. So that's why I thought I'll ask this, because it won't be a surprise if this question is asked for you in the exam.
Yeah, it seems that he was doing very well.
Yeah, exactly. I think he was doing very well. That could be the reason. Coming to the transplant session, what are the tissue typings that we do pre-transplant?
We are mainly doing the ABO incompatibility and the HLA antigen. So the HLA, the human leukocyte antigen, is part of the major histocompatibility complex, which is located in the chromosome 6, and we have class 1 and class 2. Class 1 consists of HLA A, B, and C. Which present in most of the nucleated cell, while class 2 is HLA, DR, DQ, and DP, which is mainly present on the B lymphocyte, activated T lymphocyte, macrophage, and dendritic cell.
Okay, well done. And what are the types of rejection that can happen after transplant?
We have mainly three types of rejection. We have the hyperacute rejection, acute rejection, and chronic rejection. The hyperacute will happen immediately after the transplantation, so it may happen within hours or days, which is quite uncommon currently due to proper selection of the kidney and the proper tissue matching. It's mainly due to preformed antibodies and associated with a very rapid thrombosis and death of the graft, and usually there is no effective treatment for that, and we need to do a nephrectomy and graft removal for the patient. And then we have the commonest type, which is acute rejection, which happen in about 40 to 70% of the patient. It will happen usually within a few days up to 3 months. And we have two types of the acute rejection depending on the histology. Type 1, which is the most common, is cellular dependent, mainly rely on the T cell, which is 90%, while 10% is antibody mediated. And usually it responds to high dose of intravenous steroid to start with, and higher dose of other immunosuppressive treatment. And the third type is a chronic rejection, which is time dependent, usually happen after 6 months and associated with chronic loss of the graft function, and it could be either cellular mediated or humoral antibody mediated.
Okay, brilliant, well done. Coming to the last session of this discussion, we will discuss on laparoscopy. So what are the access methods you know about in laparoscopy?
So the access, we have three methods for access, which include the Hasson technique, which is the open technique, and we have the Verus needle, which is a spring-loaded entry needle into the abdominal wall. And recently we have visualized port or VisiPort, where we have a camera through the port through the process of insertion.
Okay. What is Palmer point in relation to the Verus needle?
Sorry?
Palmer point.
I'm not aware of that.
Yeah, so this is described for inverse needle insertion when there is previous surgeries and if there is extensive intra-abdominal adhesions. Then we can use the Palmer's point, which is considered to be one of the safest entry point for a Verus needle. It is defined as the subcostal point in the midclavicular line on the left side.
Okay.
So how do you confirm that the Verus needle is intraperitoneal?
So usually we will we'll have a syringe with some normal saline, and if the fluid is coming easily going in without a resistance, and then if you aspirate, you can get some of the fluid. I think this indicates that we are in the peritoneal cavity.
Okay, this is one of the questions asked, and I think we have to tell three keywords there. This is given in Campbell. So the three keywords are: one is the first, what we do is to see the aspiration, irrigation, and aspiration test. The second one is the drop test, and third one is the advancement test. So in the aspiration, irrigation, aspiration, what we do is to we will take 5 ml saline in 10 ml syringe, and first we will aspirate to check for any bowel contents or blood contents, and if it is clear, then we will irrigate the amount of the saline, and if it is freely going in, we are happy, then we will aspirate once more, and if it is if there is no fluid returning, then we are sure that it could be in the intraperitoneum. Then we will remove the syringe, and if we can see the drop of saline falling into the tummy, that is called the drop test. And the third one is called the advancement test. When you push it just 1 centimeter after that one, it should easily go in.
Yeah.
So these are so when the question is asked about the safety of Verus needle, we can say that we will follow these 3 steps before gas insufflation.
Yeah.
What are the components of a laparoscopic stack?
So the stack is composed of 2 monitors, one for the surgeon and one for the assistant and nursing staff, a light source, gas insufflator, diaphragm, and a computer for recording, and a printer.
Okay, well done. What is the most commonly used gas in laparoscopy?
Mainly it is the CO2.
Okay, what's the reason that we use CO2?
Because it is non-combustible and it is physiological.
Well done. And it's very soluble in in blood. So it is eliminated much more quickly than the other options. So are you aware of any other options of the gases that can be used in laparoscopy?
I'm aware in patients with COPD or respiratory problems, then CO2 is not recommended to be used, and I think they use the helium instead. Exactly. I'm not sure.
So it is helium. It is helium, definitely. It is helium. And there are papers on nitrous oxide as well, but mainly carbon dioxide. Be aware of the use of helium, like you said. Are there any contraindications for laparoscopy?
The main contraindication is in patient with abdominal wall sepsis, uncorrected coagulopathy, significant hemoperitoneum, peritonitis, patient with malignant peritoneal seeding.
Okay.
These are the main contraindication. The relative contraindication include pregnancy, high BMI, extensive abdominal or pelvic adhesion.
Okay, well done. So think we will stop our discussion for today's session. I think that was a brilliant discussion. And,
Thank you.
Because one of the things that we don't want in a discussion during the first is Viva is a session where we are not practicing daily. So the hemodialysis, hemofiltration, you have good knowledge about it, and I enjoyed the discussion thoroughly. Regarding the laparoscopy, it might go in more detail, a bit more, and I haven't heard that there was any discussion regarding robotics yet, but it is always good to prepare on the basic techniques of the robotic instruments.
Okay.
Any questions regarding today's discussion?
Yes, please. If I can ask about the equivocal curve and O'Reilly curve, they may ask what you are going to do for this patient with equivocal curve.
Exactly.
So, is there any place for Whittaker test, or it is just for academic use?
No, I don't think practically we use Whittaker test anymore. There is a good description of Whittaker test on the technology book, a full chapter dedicated to the Whittaker test. We can read that and be aware of the principles, but because it involves a nephrostomy and a catheter, it's more invasive. So in cases of type 3 curve, and if it is equivocal, the recommendation is F minus 15.
Okay.
So all these curves are F plus 20.
Yeah.
There are centers where they directly go for F minus 15, but the standard teaching is we have to go ahead with F plus 20, and if there is an equivocal curve in F plus 20, then it has to be a repeat F minus 15.
Yeah.
So for example purposes, we can say that if it is an equivocal curve, because equivocal curve is F based on F plus 20. So if there is an equivocal curve, we can use the F minus 15.
Yes. Okay, thank you.
No problem at all. So best wishes. I think we will be moving towards the 10-minute sessions. So we will discuss more on the technology in those sessions. But well done today. Thank you so much.
Thank you very much.